Good morning, good afternoon, and good evening, wherever you are joining us from around the world. It's a pleasure to have you with us as we open this session. My name is Ally Hossain, and I am the CEO of the New Zealand Sepsis Trust and an elected board member of the Global Sepsis Alliance. I'm delighted to be your moderator for this session, Voices of Women, Children and Families, Advocacy, Policy and Awareness. Whilst this is billed as a panel, it's not intended to be a traditional panel discussion. It is a deliberate intervention. Because today we are not here to talk about sepsis as a clinical condition alone, we're here to confront it as a systems failure. This session is about women, children and families, but not as categories on a slide. It's about what happens when the systems designed to protect them fall short. Sepsis is often described in clinical terms, the body's overwhelming response to infection, but in reality, it is frequently the end point of something else. Delayed recognition, fragmented care, missed opportunities. We hear that all the time. And systems that were not designed or not functioning well enough to respond in time. And when that happens, the consequences are profound. For every life lost, there is a ripple effect for families, communities, health systems, all carrying the weight of something that, in many cases, was preventable. So today, we are asking a different question. Not what is sepsis? We know the answer to that. But rather, why do our systems continue to produce sepsis? And what must change at a policy, leadership, and systems level to stop it? We are privileged today to be joined by a panel of global leaders who are not only experts in their fields, but who also sit at the intersection of policy, practice, and lived experience. This is a space for honest, high-level discussion, a space to challenge assumptions, and importantly, a space to move beyond awareness towards accountability and action. Because if we continue to treat sepsis as an inevitable clinical event, we will continue to see the same outcomes. But if we recognize it for what it often is, a signal of system failure, then we have an opportunity, an obligation to do better. So, as this is a panel format, I'd like to take a minute to introduce all our panelists properly at the start so that we can allow the conversation to flow freely and naturally as we get into the session. It's a real privilege to introduce Professor Malebona Precious Matsoso, a globally respected health leader who has served as Director General of South Africa's National Department of Health and held senior roles at the World Health Organization, including Director of Public Health Innovation. She has chaired and advised some of the world's most influential health bodies, from the WHO Executive Board to pandemic preparedness panels and the G20 Health Working Group. Currently leading the Health Regulatory Science platform at WITS, her work continues to shape global health policy and access to medicines. Her contributions have been widely recognized, reflecting the extraordinary impact of her leadership on the global stage. Our panel is also very fortunate to feature Éctor Ramírez Barba, Federal Deputy, Surgeon, Public Health Specialist, Researcher, and Public Policy Leader. He holds doctorates in health sciences and public administration and has served as Secretary of Health and Secretary of Social Development. A member of Mexico's National System of Researchers, he is a 5-time elected legislator by direct vote and currently serves as Federal Deputy for the 2024 to 27 term and as Unite Chapter Chair for Latin America and the Caribbean. It's also my great pleasure to introduce Mariam Jashi, a global health leader with experience across more than 25 countries in policy, sustainable development, and innovative financing. She is the CEO of the Global Sepsis Alliance and continues to hold key international roles, including Secretary General of the Medical Women's International Association and board positions across global health networks. Mariam has served as a Member of Parliament in Georgia, Deputy Minister of Health, and led major international financing initiatives. With a strong foundation in both medicine and public health, and a career spanning UNICEF and the World Bank, her leadership continues to shape global efforts to improve health outcomes worldwide. We will also shortly be hearing from Garrett Brown, an academic respiratory consultant at University College London with a specialist focus on lung infection. He leads a research team exploring how diseases like pneumonia develop and how the immune system responds, alongside translational work in conditions such as COVID-19. Clinically, he cares for patients with complex respiratory infections across a wide spectrum. Garrett also co-leads the UCL Respiratory Department and has contributed to national vaccine policy as a member of the UK's Joint Committee on Vaccination and Immunisation since 2018. Any conversation on advocacy and survivorship must feature the voices of those who have lived experience of sepsis. So it's a privilege today to introduce Marianne Haverkamp, a sepsis survivor and passionate advocate who brings a powerful personal perspective to her work. Now based in Spain, she is dedicated to raising awareness and improving outcomes for patients and families through sharing her story on international platforms. Marianne also plays a key leadership role globally, serving as chair of the ESA Patient and Family Support Working Group and co-chair of the Global Sepsis Alliance's Survivor and Family Committee, helping ensure the voices of survivors are heard and embedded in care. And finally, it's my absolute honour to introduce Duncan Brown, a dedicated advocate whose work is shaped by the tragic loss of his son to undiagnosed sepsis in 2022 at just 18. Since then, he has focused on understanding how healthcare environments impact the quality and safety of care, with a strong emphasis on supporting those on the front line. Duncan continues to advocate tirelessly for improved sepsis awareness, both in Australia and globally. So, as you can see, an absolute powerhouse of a panel, well matched to the weight and importance of our topic today. My sincere thanks to you all for your support and willingness to take part in this important panel discussion. And don't forget, to everybody watching as well, you're most welcome to put your questions in on the YouTube chat as well. So I'd like to kick things off without me talking any further with a question for Mariam. So as CEO of the Global Sepsis Alliance and former Deputy Minister of Labour, Health and Social Affairs in Georgia, you of course have a global view. Now here in New Zealand, we do not as yet have a national sepsis action plan, and we continue to advocate to the New Zealand government very strongly for this. What would you say are the key elements that every national sepsis strategy must include to genuinely reduce preventable deaths?
Thank you, Ally. Thank you for your excellent moderation, and greetings to our truly powerful panel members. New Zealand is not an exception, but rather an example of many of the countries in the world. We only have 15 countries out of almost 200 that have elements of national action plans or full-scale national action plans for sepsis. And in the reality where sepsis is the cause of 1 in 5 deaths, approximately 20% of deaths globally, and we see only 15 countries prioritizing sepsis at national or subnational levels, this is the status quo that we have to urgently change. As for the elements of national action plans, as the former Deputy Minister and MP, of course, I realize, and I think our dear panelists from different parliamentary and government experience would agree that we do not need silo national action plans for every single global health threat or medical emergency, because holistic integrated approach to truly universal health coverage policies is key. And our priority is to make sure that sepsis is recognized as a national, regional, and global priority as part of universal health coverage packages and comprehensive national action plans. Of course, this doesn't exclude to have standalone documents that could define the evidence-based guidelines, protocols, sepsis bundles, clinical pathways to really help the frontline workers as well as healthcare administrators to provide the service, monitor, and oversight the quality of sepsis care. And another important element is that we have to ensure continuity of sepsis care, starting from prevention that is very much linked to effective vaccination, water and sanitation, infection control measures, as well as early detection, treatment, and post-sepsis care. And as Jeremy Ferrer once said, and we also hear the examples from different global health leaders, sepsis could be the best proxy indicator how well national health systems and universal health coverage works. Because if we are able to manage effective prevention, early detection and treatment of sepsis, our health systems are truly resilient and up to date to meet the modern global health and medical emergency challenges.
Thank you, Mariam. And I'd like to ask Éctor a question off the back of that, if I may. So as a parliamentarian and the Unite Chapter Chair for Latin America, the Caribbean and Mexico, following on from what Mariam said, what would you say are the most effective legislative or policy levers that governments can use to reduce those preventable deaths from sepsis? And if I may ask another question, why do you think these have not been more widely adopted across your region? And that's for you, Éctor, if you are able to answer that question for us.
Excuse me. Yes, the internet is unstable. Good morning. It's a great honor to join this panel alongside with colleagues and leaders who I deeply admire. I speak today from the dual responsibility that the clinician who has seen sepsis in the bedsides and of a parliamentarian who deals every day with the constraints and the opportunities in the political systems. We often think of sepsis as a purely clinical event associated with intensive care units and highly specialized decisions. In reality, sepsis is the symptom of a structural failure of health and social protection systems. When a pregnant woman, a newborn, a child dies from sepsis, it's almost never because the health teams don't know what to do. It happens because of poverty, barriers to access, weak primary care, hospitals without supplies, missing data, and political decisions were never made. From a parliamentary perspective, this has very concrete implications. The first is that the sepsis must no longer be invisible in our laws and policies. If a problem does appear in legislation, in official regulations, or in national plans, it rarely reaches the political agenda. That is why it's so important the name sepsis in our health acts to integrate into inequality and patient safety strategies and to connect it with other agendas that already have priority status: maternal and child health, antimicrobial resistance, healthcare associated infections, and universal health cover, like Mariam said. The second implication is financing. Producing more clinical recommendations is not enough if there is no funding to implementing them. Reducing sepsis deaths requires investment in prevention, vaccination, quality antenatal care, safe childbirth, infection prevention and control, in basic capacity to hold hospitals, triage, essential antibiotics, oxygen, laboratory, and in continuous training of health workers. It's a matter to budgetary allocations, not only on clinical goodwill. The third implication is accountability. As long as ministers and parliamentaries don't have clear, disaggregate, and regular sepsis data, sepsis will remain a ghost mortality, diluted under another diagnosis. We need surveillance systems that can answer concrete questions about many women, how many newborns, how many children are dying from sepsis, were under that conditions, and which interventions are working. And we need institutional mechanisms so that health authorities regularly report these results to legislature and citizens. But that alone don't move politics. This is why the focus of this panel is so important. The voices of women, children, families, and survivors. The agenda becomes real when legislators can put human face to the statistics. It's very different to discuss a spreadsheet than to listen to a mother who's lost her child on preventable sepsis, or to a woman who survived, who's left in permanent disability. Our duty is to create formal spaces for this voice to be heard in national committees, in parliamentary hearings, and in policy designs. Thank you.
Thank you for that. And I'd like to follow on from what you've said about the importance of having the voices of survivors and family members. I'd like to ask Marianne a question as a sepsis survivor. So we often talk about data and systems, but of course, as Éctor is talking about, every statistical case of sepsis is a person and a family. So from your perspective as co-chair for the Global Sepsis Survivor and Family Committee, what do you think survivor and family experiences reveal about where the system is failing us?
Thank you, Ally. Well, I personally, and of course, I'm very grateful for all the great research and work that experts are doing on early diagnosis and treatment. But I think that the system is failing way before that we get into the hospital. So if I take a look, for example, at my case, and knowing that say 70 to 80% of sepsis cases are starting with a normal infection at home, if I would have known about sepsis and its symptoms, I wouldn't have been so relaxed with my state in that day. If my GP, who was at my bedside, would have taken the time to really check me out and get the symptoms that I had and that there was ringing a bell at that moment. The same for the ambulance team, the first ambulance team. If they would have listened to my mother-in-law saying, this is different, this is not just a summer flu, something is really wrong here, I'm almost sure that I would have been taken to the hospital at 11 in the morning instead of at 6 p.m. And I wouldn't have ended up with a septic shock in the ICU. I really feel that way. So I think it's important. It's all about knowledge, awareness, attention, and what we do with that. So it starts way before that we get into this critical, complex state of septic shock or whatsoever. We should start where the patient is, because we can all be the patient, and we start at home in our own beds.
Absolutely. And to ask a similar, following on from what you've said to Duncan, actually, just exactly what Marianne has been talking about, we hear that families often describe as having to fight to be heard when something is wrong, as Marianne has described. What do you think that tells us about how our systems listen or don't listen? And what do you think needs to change to ensure these concerns are heard and are acted upon sooner?
No, thanks very much, Ally. And again, it's always a privilege. I'm deeply honored. As you know, this is a very personal matter to me. And so I have the highest respect and thanks to everybody that is working so hard at bringing about change. I am deeply grateful. So thank you. Yeah, Ally, I think when families say they had to fight to be heard, I think it's a sign that the system is still listening selectively and not in a structured or sort of any dependable way. I think the system still privileges what can be immediately measured or what can be clinically articulated. And in doing that, it sort of undervalues the people who know the patient the best. Families are often the first to notice that something is not right, even if they can't describe it or name it. They can see the difference, how the person normally looks or speaks or breathes, responds, or is actually coping. And the system seems to wait until these observations fit into some recognized clinical pattern, and it still treats the family concern as informal input rather as a clinically relevant data point or evidence. So, whenever I hear families are having to fight, I think, they describe a system in which listening is still too dependent on the attitude or the experience, the workload, the capacity of the individual staff member who is actually in front of the patient. And exactly what Marianne was saying, that shifts the burden of recognition and escalation into the family. And that is in itself unsafe. Look, I'm going to touch on 3 changes, I think, that from my perspective, are relatively easily implemented and would have a significant difference. I think the first change is cultural. And if we can move from a mindset of simply reassuring and sort of moving on to one of hearing the concern as data and as a part of patient safety. Families shouldn't have to, they shouldn't have to present like experts and to be able to explain things to be taken seriously. A simple statement that this is not the way that they usually behave, should be sufficient to trigger some sort of curiosity, some sort of assessment or documentation. So the second change, it sort of leads to the second change, which is, I think, is procedural in a way. Our systems need a clear mechanism that will turn any concern into action. That means family concerns should be then documented, they should be acknowledged, and then linked to a defined response. Every frontline setting should have maybe an explanation, that patient or an expectation that patient and family concern is a formal safety input. It's part of the assessment, it's part of the handover and the escalation. And so the question shouldn't be whether the staff have the capacity to listen, but whether the system makes listening routine. If concerns are heard but they can't be operationalized, then nothing will really change. And I suppose that takes me to the third sort of thing that comes to mind, and that's around accountability. And I think you mentioned that earlier. Repeated concern without a link to a defined response, that should be treated as a safety concern or a safety breach. So whether concerns are heard and acted upon it's not just a matter of compassion and competence. It really is a matter of system design and organizational conditions. We need to create the conditions within that care environment, that makes acting on concerns normal, safe, and expected, which is often not the case.
Thank you, Duncan. There's a question that's come through on the chat, which I'd like to ask to Precious, please. In South Africa, there are so many competing health challenges, yet sepsis prevention is not concerning enough to be included. But how do we incorporate sepsis policy in already stretched systems, perhaps a package of care?
Well, good morning. As I was listening, I thought perhaps we also need to, view this differently and approach this differently, in a sense that, and I agree with the previous speakers about integrating sepsis into different policies. In the same way as we say health in all policies, we should approach sepsis the same way. And I'll tell you why I would advocate for that. Firstly, I've just led negotiations for the pandemic agreement. And one of the articles is about prevention. And it actually hit me that as we're negotiating that, I had someone close to me, being treated for sepsis. I had a close colleague being treated for sepsis. And it was at the time we were discussing this. And it just occurred to me that, look, we're discussing this as part of a pandemic agreement for pandemics, not for, infections that are clinically managed on a day-to-day basis in health facilities. But I also thought about data that we've always released about neonatal sepsis, for instance. And it comes as part of our report on maternal, child, and neonatal health. So it's another process of reporting sepsis. But then it, occurred to me that I've been an advocate for AMR in South Africa. We worked on policies and national health action plans. And when antimicrobial agents fail and people present with infection, which was the case with some of the people I know, they couldn't use any of the antimicrobial agents. They had to bring the big guns, to deal with the resistant strain at the time. Now, I'm saying that as we look at a package of service, yes, we can define the package of service, but let's look at an integrated approach, one, by having sepsis in all policies so that we deal with, firstly, those who discuss universal health coverage, as I had earlier, must ensure that it's sepsis that is integrated in our primary healthcare facilities, the health workers at that level. And health workers should not just be clinical staff, it must also be cleaning staff, because we want quality health services. So as we define the package, as we determine the policies, I think our advocacy message must be about health in all policies. The second thing that I would like us to consider is the quality elements that should apply at every level of care, at primary healthcare level, at hospital level, and we must have standard approaches for each to assess quality on an ongoing basis. You know how we do emergency drills. We must also do quality drills. And so that those quality drills must be viewed as preventative measures, meaning we shouldn't respond after the fact, meaning quality drills report on how many cases we had and how are we dealing with them and how will we prevent them. So that we do that routinely. So package of services, yes, but I think we need a much more broader integrated approach and come up with out of the box ways of resolving this problem. Because even now, people will see sepsis is for, those who love sepsis. People don't see it as in maternal health. Let's see sepsis as our agenda. In, those who fight for antimicrobial resistance, let's see sepsis as our agenda. Those who are advocating for the implementation of the pandemic agreement, let's see sepsis as, meaning let's have it as sepsis in all policies, in the same way as we have health in all policies. I'll stop there. Thank you.
Thank you very much, Precious. And I'd like to follow on with what you're saying exactly with a question to Garrett. So we know that 1 in 5 deaths worldwide are from sepsis. We know it's a huge global health problem, global health emergency. So why do you think conditions such as sepsis, despite this huge scale and devastating impact globally, why do you think they struggle to gain the sustained political attention? And what shifts are needed in how power and priorities are set to change that?
Big question. But I think we are currently experiencing a phenomenon in global health policy, and it's an unprecedented phenomenon. It's what I call the retreat from the global imaginary. And what we've had in maybe the last 5 years, but maybe even longer than that, really triggered from COVID. We have the US and Argentina leaving the WHO. We have massive cuts in official development assistance across the board, not just from the United States, but primarily from them. We have interesting new movements in Africa, like the Accra Reset, where terminology of health sovereignty, reclaiming the global level, is being used. We have the pandemic agreement, in which you have really two polarized groups fighting over benefits and sharing pathogens and the benefits of sharing those pathogens. This has been, a catalyst of this, like I said, is COVID-19. We have the lowest trust ratings of public health officials and public health authorities in modern history. We have debates about everything, including vaccines, the use of vaccines, social measures to control outbreaks, the wealth gap, the incredible wealth gap that showed up during COVID. We have 8.9% debt servicing by low and middle income countries for sovereign debt taken on during COVID. And that has resulted in an 8.9% decrease in spending and health budgets. We have years of lost education. So we're really in this strange phenomenon. And in the middle of this phenomenon, the thing that has still reached high politics, or the one thing that people are still talking about quite a lot, is pandemics. And that makes some sense given what I've just said. The ask for pandemics is 31.1 billion a year, another 11.5 billion for One Health. But in that debate, we see shifts in ODA, a loss of 11% in ODA for nutrition and basic health since COVID. So it skews the conversation. And I think right now everyone has focused on this post-COVID moment. That's what they're calling it. A lot of high politics has been placed on this moment. We've seen it been radicalized, this phenomenon I'm talking about, this retreat from the global imaginary on one hand, but also an attempt to reclaim it or reform it or revive it on the other. And you see sepsis in the middle of that, right? And, I know there's been movements to try to make that relationship between sepsis and COVID as a way of getting awareness. But I guess my worry about that, and it certainly is a relationship between pandemics and sepsis, and the fact that, sepsis is a pathway to mortality, and it certainly was a pathway to mortality during COVID. It showed the lack of surge capacity. It showed a lack of diagnostic capacities when the system on its best day already struggles with it, but on its worst day during COVID, it very much struggled with it. So there is a relationship there. I think the relationship is under evidenced and could be more strongly evidenced and shown. So we see this attempt to try to get the advocacy for sepsis up on the pandemic agenda, but it's then faced immediately by this phenomenon I'm talking about, this retreat from the global imaginary. So what do I think that means for sepsis is, going back to Mariam's and everyone else's comment about we need a systems approach, a holistic approach, a UHC approach, a sepsis in all policies approach. And it's good to try to attach to this global high politics issue of pandemics. But as we're seeing with this phenomenon, it gets left behind. And it will be pigeonholed to that particular line of policy. So, and my view is that there's so much going on in global health that sepsis is going to very much struggle to get there. But the worry is trying to be part of that mainstream debate of pandemics right now and that retreat from global imaginary and everyone trying to talk about it and just inserting sepsis will lose Mariam's point about the holistic nature of our approach to it. I think it will peg itself to an event that may occur every 129 years to 344 years, depending if the evidence base about zoonotic spillover risks are correct. And it will miss out on the everyday aspect of health and sepsis. And how do you do that? How do you raise awareness at that one point? Goes back to, I think, what Duncan's talking about and what Marianne was talking about, that this sepsis occurs daily. It is a killer. It is often underdiagnosed. It is often not treated properly. It is often forgotten about. You know, I didn't know Mariam's statistic of 15 national action plans, so it doesn't even reach into the policy space. If that's my worry here, that we need to drive awareness there, and maybe not so much on these fringe events, these high politics events, because those are right now struggling to go anywhere because of this retreat from the global imaginary. And I'm not sure I answered your questions or just problematized it, but driving awareness is the difficulty, and I'm not sure pandemics is the best way to go with that, with sepsis, although it is related to sepsis, obviously.
Thank you, Garrett. No, you did absolutely answer the question, and you've posed many more. So I'm going to go back to Mariam now, actually, and ask you. So we know that sepsis disproportionately impacts women, children, and those already facing inequalities and inequities. So in your view, what is it going to take to elevate sepsis from being a health issue to a true policy priority that governments simply can no longer ignore? Just on mute there, Mariam.
We couldn't ask for a better experts and leaders for the panel, because we literally have heard some of the highlights and some of the maybe new quotes and slogans for the sepsis policy advancement. First of all, I would like to reflect on some of the suggestions, and let me go back to precious comments. Sepsis in all health policies, brilliant approach, because indeed we need sepsis in universal health coverage. We need sepsis in pandemics, because during COVID, 78% of patients in ICUs had viral sepsis, and we never spoke about it. And any future pandemic will increase the risk of infectious diseases and sepsis, and we need to be ready with pathogen agnostic early detection, surveillance, and effective treatment measures. So definitely precious, and we couldn't have a better ally than you as the leader of intergovernmental negotiation body. And when we meet in Geneva at the WHO events and board meetings, let us think how we could stronger integrate sepsis even during the ratification process of the pandemic agreement at the national parliaments. As for the AMR, again, agreeing with Garrett and you, if you look at the current available data on AMR, every national ministry, every parliament knows by heart that more than 4 million people every year die from AMR. But no one mentions that those 4.71 million estimates are part of the Institute of Health Metrics and Evaluation and University of Oxford estimates that says that only in 2021, more than 21 million people died from sepsis, and this figure included 4.71 million. So when you speak about AMR and you don't speak about sepsis either, there is an issue of competency, biased approach, or any other questions. So AMR, so sepsis is the human face of AMR, and that should be also our focus. And totally agree that the system was failing before we even reached the hospitals. Marianne, an amazing statement. Indeed, we have only 18% of pre-hospital emergency teams aware of sepsis policies and the standards of care. So across the systems, we have to make sure that we truly measure. And going back to Duncan's comment, whatever we can't measure, how it can matter for policy. So the best news I can share with you today that is very promising is that this April, Global Sepsis Alliance, together with WHO and the Society for Critical Care Medicine, through the support of Lardell Foundation, is starting a joint project. And one of the components of this project is to produce the first global report under the leadership of WHO, meaning that all member states will be engaged in this survey, the first report on health system response to sepsis. And this report will be published in 2027, and we'll have a dashboard, the global mapping, which countries where in terms of their policies, protocols, guidelines. And when we measure, when we start to monitor accountability of national governments, maybe we will see more progress in terms of national commitments. And maybe these could help us to really reduce the ghost mortality, as Éctor said, in terms of sepsis. So there are definitely very promising moves, but what we have to do is really putting sepsis on the higher agenda of member states and use the opportunities like the official side event of the World Health Assembly this May that we have already approved, and we're extremely grateful, and we invite all member states to join the event, and also going to the UN General Assembly platforms, side events, using every single global advocacy forum to make sure that sepsis is visible, we are heard, and people realize how important it is for saving lives, and of course, reducing economic burden on the systems. Thank you.
Thank you, Mariam. Question for Marianne now. So when recognition and treatment are delayed, as sadly you experienced in your case, you know that families live with the consequences long after that clinical moment has passed. What do you want policymakers and system leaders to truly understand about that impact?
Well, I think it's not the problem. What I have with, if I take a look at sepsis care, is that what I call is like, for me, it feels that it's like kind of playing on Russian roulette, right? Sepsis care it's all about to which hospital you go, in which country, and who is treating you at that moment. So that's completely unfair because you don't have the same rights at that moment. It's all about luck or not. So it depends so much on where you are, and I think we should have all the same rights in treatment, in the chances to survive. And of course, the delay. First of all, you notice in all mostly the preventable deaths, unfortunately. And besides that, if you are lucky to survive, and not everyone is as lucky to survive as I did. I mean, I have all my body parts in its place, and that is being very lucky as a sepsis patient. But sepsis leaves its marks, and it leaves scars, and not all of those scars are visible. So many patients live with mental health problems, with depression, problems to sleep, concentration problems, more risk to new infections, the complete loss of trust in your own body, and as I said before, some people unfortunately have to live without legs or arms or whatsoever. So the delay in treatment goes way beyond the unfortunate death. We have to live with the consequences of sepsis, and this is called post-sepsis syndrome in many cases, something that we do not speak about, it's not recognized, and it's certainly not treated, because people are released from hospitals with a lot of consequences, a lot of things that we don't understand when we get out of the hospital, things that happen to you and you have no idea because you get no information. You got no follow-up after getting released from the hospital, and many people are suffering in silence at home. And I think that we should really take the post-sepsis syndrome as something like something that we should treat and we should follow up, because we cannot leave all those patients suffering in silence. And I'm not just talking about people who were in the ICU, because the post-sepsis syndrome is also something that people that weren't in the ICU can experience. So I see many hospitals, and thank you again for that, they have post-ICU programs, and that's great. But we are forgetting almost 70% of the patients with sepsis that weren't in the ICU, and they are also struggling. So sepsis doesn't stop when we are released from the hospital, and that's something that we have to keep in mind as well.
Thank you, Marianne. Éctor, I'd like to ask you a question. You've worked both at the bedside and in government. Where do you see the biggest disconnect between what clinicians need to manage sepsis effectively and what the policy actually delivers?
Thank you. Why sepsis have visibility? In Mexico, we have learned that visibility, stories, and alliance. We need data that more less. Studies from the public neonatology, for example, show neonatal sepsis rates and antimicrobial resistance patterns that are higher than the high-income settings. And we know that sepsis contributes significantly to maternal and neonatal mortality. These are hard numbers that can be brought into budget discussions. Second, as I said, we need voices. The World Health Organization initiatives on maternal sepsis awareness in Mexico demonstrated when women and families affected by sepsis are heard, authorities start to recognize the problem and adapt obstetric care protocols, for example. Third, we need alliances. Mexico is actively engaged in regional efforts against antimicrobial resistance, coordinated by the Pan American Health Organization, and COFEPRIS in Mexico is our regulatory authority, and in initiatives such as the Guadalajara Declaration, for example, on sepsis from an emergency medicine perspective. These platforms help align to clinical, regulatory, and legislative agendas. For accountability, we should set explicit national targets, such as reducing neonatal and maternal sepsis-related mortality by 2030, and them in sectoral health programs, and requires annual reporting to the Ministry of Health and Social Security institutions to Congress. Only when those sepsis move from a technical concern to our political obligations, we follow up the consequence. Thank you.
Thank you. A question for Precious now. From your experience shaping global and national health priorities, what determines, in your view, which issues get recognized as priorities, and why do cross-cutting challenges like sepsis struggle to find a clear place? Like we've talked about the system listening selectively. Why do you think that happens with sepsis?
Well, maybe let me first answer your first question. The first is what gets prioritized, on the agenda. As you know, the priorities of government are determined by ruling parties in most instances. If they think NCDs are a priority, resources will go into whatever has been considered a priority. But I think the most important is that, and I can talk about the South African experience, is that we also know that it's not only from a political perspective that agendas are set. They are also influenced by strong civil society organizations. For instance, in South Africa, the AIDS movement was led by civil society. So I'm raising that as a background so that you can have a sense of how agenda setting is established. But I think the most important, which might be useful, which is what we've advocated for, is having whole of government and whole of society approaches. Because if you have structures and governance arrangements that kind of discuss some of these priority agenda items, it's quite useful. And I'll use one. We have what we call National Council that brings in private sector, civil society, research institutions, different government departments. So if you have a structure like that, I think it's very useful. And I would like maybe a kind of to draw an analogy, particularly with regard to sepsis, to see whether we can identify different areas and have that kind of national structure where they discuss sepsis jointly. Let's not have, because we release reports on neonatal deaths, and part of that includes deaths related to sepsis-related deaths. So it becomes a neonatal issue. So what you need to do is to bring those, pediatricians, ONGs, bring in infectious disease specialists, bring in health systems people, health reform, health financing, so that we have a much more integrated approach, and it involves planning. So by the time we come up with budgets and plans and priorities, we should have received inputs from all different stakeholders. This is how they can feed into the political process of setting agenda and also of coming up with the priorities, particularly the budget cycles. I think that's the most important, because it doesn't help to just have guidelines. In some countries, including mine, some of these become unfunded mandates, meaning you can have, sepsis, but if it's not supported broadly, and we've not taken it through these other processes, it becomes what we call an unfunded mandate. One of the things, and it's an idea that you can all think about, and maybe Garrett can also reflect on this. When we come up with policy, there's one thing that we had introduced in South Africa of looking at socio-economic impact analysis. People never look at the social impact of our policies. For instance, in the case of sepsis, what is the social impact? What is the economic impact? People may think it's far-fetched, but it's not, because then that helps you to also bring the evidence to show those who plan, those who budget, as to why it's important to allocate resources to prevent sepsis and also to deal with it as it happens. Thank you.
Thank you, Precious, and I'll take your advice, and I will hand over to Garrett now. I'm sure you have something to comment on that.
I think one problem with the policy space, Precious has already alluded to heavily, is the way that health systems are financed, whether or not that's from external funding or internal funding or from innovative financing or some mixed basket, or the various ways that we finance health tends to come with a set of conditions and indicators. And those indicators are usually favored if you can measure them fairly easily, so that you can then, at the end of your 5-year, 3-year, how many year cycle, suggest how well you've performed against those indicators. So one problem, particularly maybe for sepsis, is because it's so complex in terms of the policy landscape and also the clinical landscape, that it's not one of these easily measurable financing you couldn't set up an easy list of indicators where you can do that with, say, vaccines, and who you give a jab to and who you don't. You can count the number of units bought, the number of units administered. And so that's an easy way you can tie financing to it. So in the policy space, I find when I look at health systems and we look at how they're financed, particularly in low and middle income countries, but low resource settings for sure, is the money tends to be targeted towards a certain intervention with a certain list of indicators, and performance is measured against those indicators. Anything too complex gets out. Usually the return on investment is based on number of units given, sometimes on health outcomes, but usually on health outputs, and they are not the same thing. So the number of people you've seen for the number of minutes you've seen them, but not the overall health outcomes and how that affects wider society. So I think Precious is quite right. When we do a lot of these return on investment calculations, they're pretty basic. They exclude a lot of the social impacts and the social benefits that come from them. And so that skews money towards programs that are more easily administered, more easily monitored, and more easily, at least in low resource settings, accountable to the funders themselves so they can see what's called return on investment or value for money is often how it's phrased. What is the value for money? So in the case of sepsis, I imagine that in clinical settings, you would have to set up, indicators that would allow that message to get back up to the finance ministries, who then are very careful about the money that they give and the returns they see they're going to get. I find it's the finance ministers that require the most convincing when you're implementing policies, that the Department of Health or the Health Ministry will have a set of fairly good guidelines, as Precious says, and it gets the Treasury, and the Treasury then says, well, we'll fund this, we won't fund that. And that skews immediately what policies are implemented and the quality of the policies that are implemented. So I think that's a major challenge, but that's a major challenge across health systems, full stop, particularly in low resource settings, particularly in the current climate of low ODA, particularly with high debt servicing and health systems struggling with, on average, a nearly 10% reduction in health budgets at the moment due to debt servicing. So that environment creates even less momentum for treasuries to put money into middle priority or low priority or high priority items, particularly if they're hard to measure.
Thank you, Garrett. And I just want to take a quick moment just to say and just to highlight how, how global this issue really is. We've got people on the chat from Tunisia, UAE, Las Vegas, Rwanda, Nigeria, Ghana, Oman, Pakistan, New Zealand, Liberia, many, many more. These are just a few that I've just spotted in the last few minutes. So it just really brings it home to me how many people around the world recognize sepsis as a global health priority and an emergency. Duncan, I want to ask you a question now. We're hearing a lot today about system failure and system gaps, and our sincere condolences for you. You know that sadly all too well. So for families and survivors wanting to create change, what would you say are the most effective ways that you have found to engage with decision makers to influence policy rather than just raising awareness?
Yeah, thanks, Ellie. Yeah, I think, look, if I just go back to where it all started for me, I think that if you are a sepsis survivor or a family member impacted by the loss of a loved one to sepsis, your first reaction is always to jump on the soapbox and you just need to be heard. But I recognized quite early on that advocacy doesn't necessarily solve complex problems. And so I shifted. I was able to shift. I drew on obviously all my previous experience, and I have been focusing on what I observed from a staffing and cultural perspective. And and all my research since then has been on the actual care environment. So I don't think we're going to get any changes in the quality of care or in the sepsis treatment until we start looking after the people that are providing the care. The care environments play an absolutely critical role. The issue that we have, though, I suppose from a systems perspective, and I just want to just touch on what Garrett and Mariam were saying around taking, the holistic systems approach. The issue that we have in health, and this, I suppose, really will direct us to who we need to be talking to. We've all heard about, complex adaptive systems, and that's one of these, the systems where they're entirely the system itself responds to changing contexts and changes and evolves, and the system moves. The issue that we have in health is indeed obviously a complex system, but it is notoriously bad at sharing information, even within service providers. We don't learn from each other. And so the system itself does not evolve and does not change. So fundamentally, what we have in health is a system that the health professionals and people within the system are following their own individual adaptive strategies. And that could either be to get ahead or to survive, with the stresses, the strains, and the burnouts. And when you have that sort of situation, it actually makes the entire system maladaptive. And that is why we see, we don't learn from mistakes. We see repeated situations, repeated sepsis cases. So, it's the parts of the system that need to be more coordinated. So, advocating and approaching health providers and hospital systems, my focus, and I think the focus needs to be on that connection between the parts of the system. That's where the gaps are. It's not, you mentioned earlier that there's people from all around the world. There'll be health systems that are fully resourced, those that are completely lacking resources. It's not necessarily a matter of resources. I find the gaps in what we've in the system, they all happen at the interface. That initial presentation, or between triage and escalation, and between the wards and specialists, and as Mariam touched, obviously discharge and follow-up. And the system is still set up as departments and very segregated and fragmented that we've touched on. So I think, as an advocate, to bring about any sort of change, we need to be looking at that level, recognizing that the challenges within the health system. Look, I've met a lot, and I'm sure there's a lot on the show. They are good people. They are very, very good people. They want to do their best, but unfortunately, they are also navigating broken systems. And so, advocating for those that are providing the care, having some compassion and kindness and understanding for the circumstances under which they operate. That, to me, is where I think the biggest impact. Now, I've got no idea what the question was, actually, Ali. I've just rambled on here. It was something about advocacy, I think. But yes, look, you can get disheartened. You can advocate. I think it's critical as a family, and certainly a survivor of sepsis, that you want to bring about that change. But you can also be easily dismissed.
Absolutely. And you did come back to the question, and it's just what you said is very valid, and we thank you for sharing those. And actually, what you said about there being gaps in the system. We had a comment, actually, someone saying from the sepsis research group of the GSA, they promote early detection through SOFA and sepsis 6 golden hour management, but they're challenged with little capacity for early pathogen identification in Nigeria. So a classic example of what you're talking about is you can have all the will in the world and the best care, but there can be gaps or system failure that just simply lets down the best care that is available. We do have the luxury of going on for a little bit longer, so I just have a few more questions I might ask. Another one for Mariam, if I may. So in the opening session of the World Sepsis Congress yesterday, at which you spoke, Tor Lerdal spoke of the urgency of investing in the global sepsis response. Do you think framing sepsis as a cross-cutting indicator of health system performance, as opposed to a standalone priority, would assist in achieving system change?
Absolutely. Ally, and I think that I do believe that the investment case of sepsis should be based on the integrated holistic approach as the best proxy indicator of the health system performance. For moving forward, as many of you know, last year, Global Sepsis Alliance developed the first multi-year global strategy, the 2030 Global Agenda for Sepsis, that actually is built on the 5 strategic pillars, including political leadership, health system readiness, whole of society approach, research and development, and sepsis in pandemics and other emergencies. Theoretically, we know exactly what needs to be done. But answering the how question, how to make sure that we reach the decision makers and the right decisions are made, I believe we have to be more creative and more persistent, especially as Garrett noted in the current challenging global health environment in terms of funding and overall architecture and diminishing multilateralism and increasing focus on sovereign health policy aspects. I do believe that, first of all, we have to put sepsis on the agenda. We have to make sure that we speak about sepsis as often as possible in every major global health forum. Again, we cannot have the cause of death of every 5 person globally and not speak about sepsis in every 5 forums, every 5 assemblies, every 5 national hearings at the parliaments or the ministerial kind of review meetings. Second, we have to reduce fragmentations, both at clinical level, as Duncan and Marianne noted, as well as the policy level. So we have to use this holistic, like sepsis in all health policy approach, definitely. And in terms of the investment case, I really see very optimistic this new initiative of larger foundations supporting the first joint program of the Global Sepsis Alliance, WHO and SCCM, that when the countries will be requested by WHO, when the member states would be asked specifically what policies and actions are taken in terms of sepsis, even as part of the ecosystem that is emergency, critical, and operative care. We're not speaking about sepsis standalone tool, but sepsis as part of the emergency care. But this is still an excellent beginning for us to make sure that sepsis is visible in WHO policies. And most importantly, in 2017, with the leadership of Germany and other German-speaking countries, the World Health Assembly adopted the very first resolution on sepsis that was asking the governments to prioritize sepsis. More than 8 years have passed, so it's time to renew the resolution. And I believe that renewing the resolution with more concrete recommendations for the resolution, the document that will have more kind of teeth, as they say, in terms of the technical details, how to guide the member states and stakeholders to really prioritize sepsis, develop national action plans, develop quality assurance standards. That should be the next step for ensuring that we also create the investment case. And finally, some of the numbers that are still available. Yes, sepsis is one of the high-cost intervention because we cannot avoid the majority of preventable cases. And for every patient treatment, direct medical costs are 36,000 euro. It varies, of course, from one country to another, but that's the global average. And sepsis, even today, costs 2.65% of healthcare budgets. That is equivalent to 0.33% of global national products. Those are huge numbers. And learning from Australia, learning from British Columbia, Canada, learning from UK, we know that investments in sepsis saves lives and saves costs. We're speaking about 6-fold investments in the case of Australia and 112-fold return on investment from Canadian example of British Columbia. So we do have elements, but we now need a very well fully pledged investment case.
There's a couple of questions coming in on the chat, and there are two which are quite similar. I'm going to just ask them both, and I'm going to direct them to you, Éctor. Laura from Argentina has said, how do you manage sepsis at a health systems level when your health system is fragmented and broken, such as ours? And there was a similar question from someone in Somalia saying our health system is fragile. How to integrate health system policy to improve early detection and prevention of sepsis in children in a low resource setting? So those two quite similar questions. A big question for you, Éctor.
Thank you, Ali. Yes, in Latin America and the Caribbean, health system fragmentation and inequity remains a major challenge. Mexico illustrates how fragmentation and inequity translate into worse sepsis outcomes. We have highly specialist national institutes and tertiary hospitals with advanced technology, but also general hospitals or community facilities that struggle to secure basic supplies, adequate staffing, or timely access to antibiotics. Recent research in our country and in a large university hospitals in Mexico documents high rates of late onset neonatal sepsis associated with resistant pathogens, reflecting both gaps in infection prevention and limited access to effective therapies. Information is also scattered across multiple subsystems, federal and state ministries of health, social security institutions, and the private sectors. So many maternal, neonatal, and pediatric sepsis deaths are never analyzed together as a national problem. What reforms we considered urgent? At least three. First, building integrated service network that includes clear sepsis care pathways so that newborn or a woman with severe infections in a rural community has a rapid, predictable road to facility with the right capabilities regardless to insurance scheme. Second, strengthening primary care and general hospitals with concrete quality and patient safety measures, device-related infectious bundles, strong hand hygiene programs, and active surveillance. As Mexican hospitals have shown, can significantly reduce bloodstream infections when implemented systematically. Third, advancing legal and regulatory frameworks that mandate data interoperability and sepsis reporting, aligned with national strategies on antimicrobial resistance and patient safety. Only then will we be able to identify hotspots and direct resources where they are most needed, instead of working in the dark. Thank you, Ali.
Thank you. Garrett, a question for you. What is the dominant health narrative in the global public health governance lexicon, would you say, at the moment? I'm going to give you a big, meaty question to finish.
I mean, I sort of answered that before. It is the pandemic agenda that everyone's talking about that. They're meeting today to try to finalize what was Article 12 and get that over the line. I have my doubts that it will. So that's the big narrative. And I would say, what's the sort of dominant paradigm at the moment? I mean, and this talk goes back to awareness. There seems to be an over fetishization, and I'm careful to say that, but I think there is, that focuses on zoonosis spillovers and emerging infectious diseases. And we were absolutely obsessed with them in the media. Anytime there's a minor outbreak, it gets escalated to be the next big pandemic. We saw that with Mpox recently. We've seen that with MERS. We've seen that with SARS. We've seen that with Zika. And it gets a lot of immediate attention and a lot of awareness, but that crowds out AMR, re-emerging infectious diseases. It crowds out sepsis. It crowds out social determinants of health, or the social determinants that lead to disease, poor nutrition, poor sanitation, environmental encroachment, whatever it is that that are the sort of the drivers of these outbreaks in the first place, those all get crowded out. So what we end up doing is we're highly aware of an infectious disease, an emerging infectious disease. It's the next big zoonosis, and a ton of resources and media attention and policy attention go to that. And that, I think, has detrimental effects on a much more holistic and systems approach to even thinking about global health. Let me just give you some numbers, and this will kind of bring it home. I mean, we've all heard about Zika, we've all heard about SARS, and we've all heard about MERS, but all of them have killed less than 1,000 people each. Now, Mpox, in the DRC when I was studying it, had killed 55 people at that moment. And there was talks about getting a smallpox vaccination in there that was going to cost roughly 2.5 million per life saved. And we came in as economists and said, well, that's weird in a culture where the average spend on a person's health a year is $22. What are the opportunity costs of this? And there was some indications already that traditional public health measures were having some success in dampening down Mpox, which turned out to be the case, and it's fairly manageable at the moment. So I think that's one of the landscapes that we have. We have these two strange phenomenons taking place at the global level. One is this post-COVID moment where people want to retreat from the global level, while states and others are still quite obsessed with this idea of zoonosis spillover and emerging infectious diseases, but while doing that, seemingly put everything else on the secondary burner. And that motivates a lot of the political actions that are taking place right now. If you look at everything put in place for pandemics right now, it's all on this sort of biomedicalized surveillance model. So we have the pandemic fund. It only finances surveillance and diagnostics. We have the biohub in Germany, which is where all these pathogens will be set, where they can be diagnosed for countermeasures. We'll have a countermeasure distribution system with innovative financing, purchasing agreements, and all these other wonderful things. And then we have the CEPI 100 Days mission, which is to create a vaccine within 100 days once a pathogen of risk has been identified. That's what we have. That's where the money is going. And so everything else is kind of getting crowded out at the moment at a time when we have decreasing ODA and we have decreasing attention and decreasing trust and, big national health debt servicing problems. And it all kind of escalates into this massive, perfect storm. I don't know if I answered your question, but that's what everyone's focusing on. And I've been trying to say, hey, look, what does the evidence say about the risk of pandemics? What does the evidence say about zoonosis risk? Can we just get a more proportional approach to this that weighs these other issues equally and not just put all our eggs in one basket in this very narrow paradigm of biomedicalized securitization that ignores all these other things? And that's the problem at the moment.
Mariam, I'm pretty sure you're going to have something to say about that.
Ali, thank you for this opportunity because I wanted to immediately respond and reflect on Garrett's intervention. And absolutely, it's difficult to understand the logic behind some of the discussions around prioritizing the global health threats that have much lower, significantly lower burden on societies and medicine, kind of health sector, or the overall economic space and fiscal space also of the countries. Of course, every life should be saved and supported. And of course, we cannot put any price tag to any single life, even if we see the pathogens affecting hundreds or a few thousand of patients. But when we have the global cost that takes every year 11 million lives, and it's the leading cost during the disease outbreaks and pandemics, and not seeing sepsis in the agenda of the health emergency preparedness discussions, that is truly surprising. And in this respect, I just wanted to give you again some optimistic news. 2 years ago, when the Global Sepsis Alliance, through the European Sepsis Alliance, became the party of the civil society discussions at HERA, the Health Emergency Response Agency of the European Commission, we were not hearing anything about sepsis. So we're extremely grateful that after our continuous advocacy and persistent efforts to convince and to make the strong sepsis case, in March, the European Commission announced historic allocation of 244 million as a research accelerator as the countermeasures to health emergencies against infectious diseases, ARDS, and sepsis. So we really think that every effort to try to be heard, try to really spread the word and speak with the policymakers and decision makers is important. And I really hope that in the next rounds of pandemic negotiations, sepsis could be stronger represented. Thank you.
Thank you, Mariam. Well, I'd like to say a big thank you to our panelists for an honest, challenging, and deeply important discussion. What we've heard today reinforces something we can no longer afford to ignore. Sepsis is not a clinical inevitability, it is a systems outcome. It reflects how well or how poorly our systems recognize risk, respond to deterioration, and connect care when it matters most. We've also heard that timing is everything. The earlier systems act, the fewer lives are lost. And it's not just about frontline clinicians. We've heard how much they care. It's about how policies are designed, how services are structured, how data is used, and how seriously we take early warning signs across the entire system. Finally, there is a clear challenge for any of us working in policy, leadership, and system design. If sepsis is not embedded in our core frameworks, then those frameworks are incomplete. Because what sepsis exposes, gaps in recognition, delays in response, inequities in access, are not isolated issues. They are signals of broader system performance or failure. So the question we leave with is not whether we can do better, it's whether we are willing to design systems that do better, consistently, equitably, and in time. Thank you for being part of this conversation and, more importantly, for the action that must follow. My sincere thanks to you, the audience, for your time and your interest and for those brilliant questions. And I will now close the session and encourage you to please visit the Global Sepsis Alliance website and consider signing the World Sepsis Declaration. Don't forget to follow us on Facebook, Twitter, Instagram, LinkedIn, and TikTok. And finally, our grateful thanks to all our sponsors for this, the 6th World Sepsis Congress, and of course to all our panelists for their insight and time. Thank you very much.